Our next speaker is Raphael Itzykson from Hospital Saint Louis in Paris, and he will talk on the treatment of CML, including RAS mutated.
Thank you, Guillermo and Joanna. Thanks, everyone. Happy to discuss here the treatment of proliferative CMML. Unfortunately, I think I will raise more questions than give definitive answers, as you can expect. These are my disclosures. So we know that the clinical presentation of CMML is heterogeneous, and myeloproliferative features include hyperleukocytosis made of majority of monocytes, but also immature myeloid cells, as well as enlarged spleen and other extramedullary symptoms. And we have to acknowledge that even in careful multivariable analysis that account for the most recurrent gene mutations, high white blood cell count still retains independent adverse prognostic value. There has been extensive investigation what would be an optimal cutoff, and it's pretty close to what has been retained in WHO classifications, around 13 to 15, regardless of the study. So it's one has to keep in mind that the monocytic hyperplasia in these patients is not composed of normal monocytes. This is a study we performed, transcriptomic study that we performed a number of years ago, where you see that the majority of patients with proliferative CMML have an aberrant monocyte transcriptome, and these are the patients that fare poorly. Furthermore, the Solari group a few years ago showed that even when you look at cells that are morphologically bona fide monocytes, they are in fact composed of a subset of cells that are in fact closer to immature myeloid cells with MDSC-like properties that both inhibit normal monocytic to macrophagic differentiation, that contributes to the accumulation of monocytes in these patients, and that may also have immunosuppressive properties that the lab is currently investigating in further detail. So I'll take a time to discuss the pathophysiology of proliferative CMML, because I think it has profound implications for therapy, which is the primary aim of this talk. So our first idea on what gives rise to these proliferative CMML is GM-CSF hypersensitivity, as was nicely discussed by the previous speaker. And this is because we think of GMML, where virtually all patients have the RAS pathway alterations, and where spontaneous GM colony formation is found in, and is in fact a minor diagnostic criteria. However, the story is a little bit different in CMML, and even with whole exome sequencing data sets, one can find bona fide RAS pathway mutations in only, let's say, 50 to 60% of all CMML all-comer studies. And a few years ago, we performed a small-scale study where we carefully investigated GM-CSF hypersensitivity in colony-forming assays in very stringent conditions. And as one can appreciate here, only a subset of patients have really a GM-CSF hypersensitivity in vitro. And in fact, these are the patients that harbor the RAS pathway mutations that we all know. So it means that their GM-CSF hypersensitivity is confined to a subset of patients where RAS pathway mutations can be found even with a restricted gene panel sequencing, and this has largely been confirmed by studies from our Austrian colleagues and by the Padron lab as well. So then it means that this is the white blood cell count of these patients according to the presence or absence of GM-CSF hypersensitivity. So you can appreciate that there are two groups, in fact, of proliferative CMML. One that is characterized by GM-CSF hypersensitivity and RAS pathway mutations, and then there is this other group. So what is this other group? We turn back to our genotype-phenotype correlation that we published a few years ago. And in careful multivariable regressions, one can identify that on top of the RAS pathway mutations, presence of ASXL1 mutations are independent predictors of high white blood cell count or splenomegaly, even though we acknowledge that ASXL1 and RAS pathway mutations do cooperate. So if you can think of a disease that has high frequency of ASXL1 mutations and that has GM hyperplasia, you immediately think of a typical CML, where we know that there is cooperation between ASXL1 and SETBP1. And in our retrospective CMML registry, we found that actually a subset of these proliferative CMML with ASXL1 mutations have SETBP1 mutations. They are not exclusive of RAS pathway mutations, and they are characterized by a higher percentage of immature myeloid cells, suggesting really a phenotypic continuum between proliferative CMML and a typical CML in a subset of patients. And data from the Kitamura lab, where they generated the mouse model with combined ASXL1 and SETBP1 mutations, really recapitulated this atypical CML phenotype. But most importantly, they performed some chemical investigation in vivo, where they showed that inhibition of the activation, of the PP2A phosphatase did not restore the survival of these mice, suggesting indirectly and partly only that ASXL1 and SETBP1 proliferation is not dictated by AKT and ERK pathway activation. So my current proposal is that there is in fact three types of CMML. One that is myelodysplastic, and we showed a few years ago that the mild monocytosis that is seen in this patient is caused by biased myeloid differentiation at very early stages of myeloid commitment, in particular due to the clonal burden of TET2 mutations in the stem cell compartment. But I would suggest that there are in fact two subsets of myeloproliferative CMML. One that is reminiscent of JMML, that is characterized by RAS pathway mutations and GM-CSF hypersensitivity, and we've seen earlier a very nice collaboration between TET2 and RAS. But there may be another subset which is closer to a typical CML, where the mechanisms of proliferation are still a bit unclear to me, and that probably has to be treated in a different way. And I think we have to keep this in mind for treatment. So let's turn to treatment. That's how I tend to think of my CMML patients. I try to bin them into prognostic categories, even though I acknowledge that there is no definitive prognostic scoring system for these patients. And then I have to consider the dominant symptoms, whether they're related to myeloproliferation or myelodysplasia, even though, again, in a subset of patients, you have to account for both. So I think the statement that the only curative options for CMML remains stem cell transplant is obviously true. And I must also say very quickly that we've been hindered in our clinical studies by the lack of CMML-specific response criteria that could capture improvement in myeloproliferative threats. And as an international consortium, we've come up with these international criteria a few years ago that we've been able, and others, to validate retrospectively, and that will make us more comfortable in the coming years. So the treatment goals in proliferative CMML: try to cure the disease, so you have to consider transplant in every patient. If such, how do you bridge to transplant? If you cannot consider transplant, do you need to delay progression? Otherwise, you're just facing coping with symptoms, including those that are related to splenomegaly. So we've proposed a few months ago European guidelines for the management of CMML. Obviously, most of it relies on expert consensus, so it's much more a roadmap as to what we need to achieve in CMML in the coming years. So coming to allergenic stem cell transplantation, we know that in unselected CMML cohorts, the rate of relapse is still extremely high, around 35%, and in a series of multivariate analysis, including those carried by the French Bone Marrow Transplant Society, it was shown that actually splenomegaly is an independent predictor of worse outcome and higher cumulative incidence of relapse. So splenomegaly in CMML is made of probably several components. There are a subset of patients where it is partly caused by myelofibrosis, or is this prognostic value of splenomegaly just a proxy for a specific clonal workup in these patients? And very nice data from our Japanese colleagues show that indeed patients with RAS pathway mutations have really bad outcome after stem cell transplant. So we still have to make this careful multivariable analysis to understand whether there is some cell intrinsic properties of RAS mutated CMML that makes them relapse after transplant, and if so, through which mechanisms, or if splenomegaly has by itself adverse outcomes, such as in myelofibrosis. So in those patients that you want to refer to transplant, you sometimes have to bridge them to transplant. Obviously, we have retrospective data from patients treated with hypomethylating agents. This is obviously methodologically always very difficult to interpret, but there is a trend in this study from the CIBMTR suggesting that delivery of HMAs prior to transplant may transfer into benefit, although there was no specific sub-study on the proliferative subset of CMML in this study. So in those patients that cannot be considered for transplant, you really want to delay progression, and if you copy-paste the way we think of MDS, you would immediately think of hypomethylating agents. To design those European guidelines, we reviewed 17 studies, and there have been a couple more recently published. And to give you a flavor of all these mostly retrospective or small-scale prospective phase 2 studies, the overall response rate is about 50%. The complete response rate is 25%, so it's in the range of what you would see in high-risk MDS. There has been regression of myeloproliferative features, but this was poorly captured in most of these studies because they applied the MDS-IWG criteria, and nonetheless, myeloproliferative CMML still retains adverse prognosis in HMA-treated CMML. At least in 2 distinct studies, propensity score matching was applied to determine retrospectively whether there was superiority of one hypomethylating agent, first-generation HMA, over the other. And in both the MD Anderson study and ours, we could not find any difference between these 2 agents. We also performed an international retrospective analysis of 174 patients with gene mutations available, most of them treated with azacitidine, but also some with decitabine. And we could see that in multivariable analysis, this is an unselected CMML population. Actually, mutations in RUNX1 and the TET2 mutated ASXL1 genotypes were the only ones that retain independent prognostic value, either positive or negative, suggesting that RAS pathway mutations, which are associated with proliferative CMML, do not carry intrinsic poor prognostic value in HMA-treated CMML. So the role, of course, and the precise positioning of HMAs in proliferative CMML in the therapeutic sequence remains to be addressed, and I'll come back to that in a second. But in most of our patients, you really think you want to cope with their symptoms. And I think it's important to think of why we want to mitigate myeloproliferation in CMML. It may not be that obvious, actually, but in this very nice study, what is striking is that if you classify patients according to the WHO classification, so the 13 gigs per liter cutoff, one can see that really proliferative CMML have worse overall survival, but this is not necessarily due, at least in this specific cohort, by higher rates of transformation to AML. So it may be, of course, disease progression that do not meet full criteria for AML transformation, but I think studies on cause-specific mortality are really required. And we now have really nice data from the Padron lab showing that CMML often have elevated levels of inflammatory cytokines, and how this affects quality of life and may affect non-AML death remains to be addressed. So when you consider mitigating myeloproliferation, we turn to cytoreductive agents, and at least in Europe, we still use hydroxycarbamide, hydroxyurea. This is, I'm always happy to show this slide. This is the only randomized phase 3 trial I know of in CMML. You see that it's been published more than 20 years ago by the Lille group, showing that hydroxyurea was probably better tolerated and thus given over a prolonged period compared to then oral etoposide. And interestingly, this old study had coined CMML-specific response criteria, which are slightly different from the international criteria, but that explained why this study reported an overall 60% response rate in this study. However, I think really very simple and practical questions such as when to intervene and what is the impact of hydroxyurea, both positively or negatively, on the overall disease course remain important questions for the vast majority of our patients. So we all agreed that there was no real robust white blood cell count cutoff to start hydroxyurea, and that probably one should think of general symptoms to do that. But again, we need studies to correlate proliferative threats and quality of life. This is just a small snapshot as to what could be the answer. So this is data that we published quite a few years ago when we studied the clonal architecture of CMML. And this is the typical patients you would treat with hydroxyurea, saying, well, he has high white blood cell count, but otherwise he's faring pretty well. So let's give him hydroxyurea and give him some time, and then we can discuss later. And what happens to the clonal architecture of these patients is that when you look at the progenitors and the more differentiated cells, over 1 year of hydroxyurea, you don't see any change in the clonal architecture. So, okay, you're just, the disease is completely stable, so let's keep with hydroxyurea. But when you zoom in on leukemic stem cells, at least with this limited phenotypic definition, you can see that, in fact, the most mutated clone is nicely invading, actually, the bone marrow, suggesting that maybe early intervention could be beneficial in these patients. And this is pretty much what we are currently addressing in a randomized phase 3 studies. That was the first study launched by the European ENSCO structure with the collaboration, fantastic actually, collaboration with our Italian-German colleagues. And this is a very simple study. We take patients with proliferative CMML and a bunch of adverse criteria, and they are randomized to hydroxyurea alone or decitabine. And there is a composite primary endpoint of event-free survival, and we acknowledge that a vast majority of patients that have been randomized to the hydroxyurea arm and that exit the trial then received probably off-label HMA. So I think this trial will address the question of, do we need to intervene with HMAs early, or can we wait until we're not satisfied anymore with hydroxyurea? And we are now nearing completion of inclusions. This has been a very large and intensive collaborative efforts, and I hope that in maybe in the next NDS symposium we have some definitive results from this trials. So regarding targeted therapies in CMML, so one can think of targeting the GM-CSF pathway, and this has been already very nicely discussed by Dr. Shi previously, and I will also mention a couple of other targets. So the oldest studies we had trying to target the RAS mutations with farnesyltransferase inhibitors, we know very well now actually why this will not work in RAS-mutated CMML because of alternative post-translational modifications that cope with inhibition of farnesyltransferase. We have already discussed the relatively disappointing data we have with trametinib as a MEK inhibitor, as a single agent in CMML, and I think one of the reasons of these relatively disappointing trials is, again, has been discussed earlier regarding the RAS feedback mechanisms. And we also have more positive data from two other agents, ruxolitinib to try to inhibit JAK2 and phospho-STAT5 in these patients, and the CD123 SL401 targeting construct. I'm still struggling to pronounce the other full name of the drug. So ruxolitinib, there have been around 50 patients treated in a phase 1, then phase 2 trial in US centers. It's doing as in myelofibrosis, it's mitigating inflammatory cytokines levels, and again, there were few hematological response captured by NDS criteria, but there are spleen and general symptoms improvement. There is even suggestion of prolonged survival compared to a historical control. So again, we have to investigate what is quality of life, what is wasting syndromes in our proliferative patients that otherwise have no blast access, to understand whether there is room for a therapeutic intervention that could even prolong survival in these patients. SL401 in CMML, This is data that Mrinal Patnaik presented at the last ASH meeting. The striking results of this early phase trial is that virtually all patients with enlarged spleen size at study entry had a reduction in spleen size. So I think personally, I'm not completely sure whether a reduction of splenomegaly is a really important point in all proliferative CMML, but one can think very simply that if enlarged spleen is an adverse prognostic factor prior to transplant, maybe reducing it, it's a very simplistic reasoning, I agree, with such compounds may prove beneficial. So this is the current status of the guidelines. It recommends it's very careful to restrict the indications of HMAs, at least for Europe, to those patients that are not proliferative until we have the results from the Dakota trial, and we otherwise are stuck with our good old hydroxyurea. So a couple of questions regarding what I think is the road ahead. So we have to think of what is the optimal bridge to transplant in proliferative CMMLs. Is it HMAs? Do we have to think of spleen reduction with ruxolitinib as we've been investigating myelofibrosis or with newer compounds? What is the role and timing of HMAs in proliferative CMML that are ineligible for transplant? And this, I think, will be addressed by the Dakota trial. What is the impact of myeloproliferation on quality of life or non-leukemic death, and how best to mitigate this? And again, I think regarding targeted therapies in these patient populations, I would suggest to consider that there are maybe two subsets of proliferative CMML, one where we have to explore synergistic combinations that are able to really tackle the MAP kinase pathway activation in these patients. And I think we have basic science efforts and probably unbiased screens to perform to uncover therapeutic ways to modify ASXL1 mutated disease across myeloid neoplasms. And I would like to finish by acknowledging all our collaborators, both at my institution, Saint-Louis Hôpital, the Groupe Francophone des Myelodysplasies, all are very nice EMSCO and US and Australian colleagues, as well as people who are involved in CMML biology in Michaela Fontenay and Eric Solari's lab. And thank you for your attention.
Thank you, Dr. Itzykson. Any question?
Good morning. That was a really beautiful talk, Raphael. Eva made the point yesterday, I forget exactly how she put it, but basically like saying CMML was like a p53 mutated blah, blah, blah in terms of outcome. Yeah, I agree. And, you know, there's the whole send them to transplant. You know, and I've sent patients to transplant over the years, and I'm not sure any of the patients I've ever sent to transplant has ever really been cured. And you can't really get the data because, you know, the series you maybe see at 20%. So do you have any thoughts about why that is, and do you have any approaches to post-transplant approaches? Because, you know, what's the point of transplanting all these people if at the end of the day they really do all relapse? Or can you identify, do you know of a subset that actually doesn't relapse? And really, because I'm kind of lost there.
That's a tough question. So obviously, I cannot say that I've seen all of my CMML transplanted patients relapse, but probably we still need some extra follow-up. I would just come back to the first part of your question, which is probably very provocative. So you say, and Eva said, it's like TP53 mutated disease. I think the striking feature of CMML is that it doesn't have p53 mutations. So is there something else in CMML that, you know, phenocopies what p53 does? That's a provocative question. So regarding post-transplant interventions, so I think there are things we can probably do to improve the outcome of transplant in these patients, and it's as in other myeloid neoplasm, it's both prior to and after transplant. So really have so each of these interventions poses really great challenges in terms of clinical trial design. So probably pre-transplant interventions are those. We're still in a very relative early era of really designing clinical trials that are dedicated to CMML. So we may not be too ambitious, but at least I think testing these new agents such as RUX or or SL401 prior to transplant is the first thing we have to consider. And obviously, given the widespread presence of epigenetic mutations in these patients, post-transplant interventions with hypomethylating agents is something we have to think of. I think the CMML community has to be very happy that non-proliferative CMML are still included in all these MDS trials so that we get messages. But I think we have to tell, especially to our colleagues from the pharmaceutical industry, that now we have international response criteria and a very good understanding of the disease so that we're ready to do careful studies in selected proliferative CMML.
Yeah, I think in the studies that are available in the States, fewer and fewer MDS trials are including the non-proliferative CMML. And I think many of us for a long time have thought it probably wasn't a great idea to lump them in because it's always this little subset, even from the old CALGB 9211 study, you can't really parse it out. So there's plenty of CMML going around, and it seems like there should be lots of studies for CMML, so that you should do that.
Thanks.
Any more questions? Well, I just one question, and I would like to know your opinion on, given the heterogeneity of the disease, the results that are emerging on the different molecular biology that may drive the disease in CMML, do you think that we should start considering treating the patients not only based on symptoms or leukocyte counts and also try to use the genetic information for deciding treatment?
That's a tough one. So again, I think we have to stop saying that CMML is heterogeneous. I mean, every myeloid neoplasm is heterogeneous, and my personal opinion is that probably CMML is somewhat less heterogeneous, at least in terms of its molecular makeup than other myeloid neoplasms. And I think we have to really make efforts to try to design molecular categories, even though there are limited, so that we can really get a sense of what patient population we've addressed in this specific study and what happened. So regarding let's say, gene mutation and their role in personalized, let's say, management of CMML. So I think now we're all ready to use gene mutations as part of prognostic scores. There are 3 very carefully controlled and independently validated CMML scores that include ASXL1 plus or minus other mutations. And we are doing efforts to design an international one, because all of these are performing somewhat similarly. Regarding therapeutic interventions, I think we have this data suggesting that the TET2 mutated ASXL1 wild-type patients, again, have a higher response rate and also a higher overall survival. But the question at the end is probably these patients do not have, very stringent criteria, at least with European standards, to be treated with hypomethylating agents. So that's another question. So I think the one pathway that probably can be targeted is the MAP kinase pathways, and it's very satisfying to know that even with a limited gene mutation panel, we can really capture this patient population.
Thank you very much, Dr. Itzykson.